Everyone, my name is Ryan from IKN, and what we want to do in this video is give you a very general overview of the approach that we use at IKN to assess and treat or load what we call the neuromechanical system. We'll go through some of the concepts and thought processes that we use to guide our assessment and ultimately what we use to guide our interventions. So IKN really is an approach that we've put together to try and target the interactions across our movement system and target how the nervous system interacts with different parts of the anatomy and how that interaction can change when the movement task changes or when the environment that we're moving within changes. Because we feel this is not something that's often integrated into many assessment and treatment approaches out there. There's an awful lot of emphasis on the biomechanics, but very little understanding of how the nervous system distributes control across the mechanics and how everything can change under different conditions. Okay, so we'll start by working through some of the concepts that we use and then integrate them into some early phase lower and upper limb loading scenarios. And then finish off by covering the importance of loading the more higher order systems like the visual system and the vestibular system and how these systems have a big influence on the muscular behavior distributed across the system. So again, we use a neuromechanical perspective to appreciate human movement, okay, which really just represents that we're not just looking at joint angles in isolation. We're not just looking at muscular activation in isolation across the periphery of our anatomy, but we want to understand what that means from a neurological standpoint as well. And that's really important there because it's that interaction between the nervous system and the anatomy that can really help us understand how we can restore appropriate muscular and joint behavior during movement. Okay, and as you said before, it's about this interaction, not just how the nervous system interacts with the anatomy, but this interaction here between the neurology, the anatomy, and the environment. Okay, and this environmental influence is really important because the environment is where the forces come from that impact our anatomy, that impact our movement. So we need to appreciate the external environment or the external forces that challenge our movement system. Okay. And if you can even take that a step further as well and understand that the external forces from the external environment is what has largely contributed to this unique architectural organization across our anatomy. So for example, we see much less muscle mass distributed around the hands and the wrists, the feet and the ankles, with more long free tendons distributed distally, where we have much more muscle mass distributed proximally. Okay, and we can ask ourselves, well, why does everyone have that unique architectural muscular organization? And it's largely because having those features distally allows our system to respond much faster to the external forces and perturbations that are acting on our system, and ultimately makes the distal tissues more sensitive to those perturbations, which is a good thing. But if we had a lot of muscle mass distally, this wouldn't be very energetically efficient at all to manage those perturbations, to manage those disturbances acting on our system. So if you can imagine walking around all day with heavy ankle weights around your ankles versus a heavy backpack on your back, I'd much rather have the heavy bag on my back, okay? So this is one of the many reasons we need to appreciate the environmental forces or the external forces that ultimately have an influence on the behavior of our joint tissues, our muscular tissues, and obviously the nervous system as well, okay? And another key concept here for us is the separation of motor or movement behaviors into two fundamental task constraints, and those are managing or controlling disturbances acting on our system. So managing or controlling disturbances would be it would ultimately represent those external forces acting on our anatomy from the external environment, and understanding what kind of neural, muscular, and joint behaviors need to be expressed to effectively manage those external forces, those perturbations. And the second task constraint is force production, okay, where we're not necessarily trying to organize our system in such a way to control perturbations or manage the uncertainty of external forces, but now we're trying to overcome those external forces. And to really simplify that using just a muscular lens, you can think of controlling disturbances as being more linked to more of an eccentric and isometric bias in terms of muscular behaviors, while producing forces will be more linked to more concentric behaviors. And it's obviously much more complex than that, but it's important to appreciate the differences between those two different task constraints and how they influence our motor, our movement behaviors. Okay, and we can further view these two different task constraints through the lens of other interactions as well. So we could view the capacity to manage disturbances or manage perturbations as more of a bottom-up strategy, where we don't want the nervous system to micromanage. We don't want the nervous system to pre-plan the behavior of our muscles and joints before we deal with the forces acting on our system. But we ultimately want to let the external forces guide the behavior of our muscles and joints. Okay, and what you'll often observe in people experiencing persistent pain or persistent movement limitations is that they're often pre-planning their movements, and the central nervous system is expressing these overprotective, top-down behaviors through the expression of heightened levels of muscle activity or the expression of pain. Okay, we're expressing these overprotective behaviors, and we're not able to shift the attention into the external environment to deal with those forces. Okay, we can also see this through more a distal to proximal lens as well, and how this more bottom-up strategy would bias more of a distal to proximal dominant strategy, where the distal tissues are dealing firstly with those direct forces. They are in direct contact with the external forces, and then they share those forces proximally. Okay, and then lastly, if we consider this interaction at the top, this interaction shifts to where the environment is more so guiding what's happening at the anatomy and the neurology, not the other way around, which is what we see with more of force production strategy. Okay, so if we look at now a force production strategy can represent more of a top-down strategy. Okay, where the nervous system now has to express or produce more muscle activity than the external forces acting on our system. And because both the nervous system itself is proximal to the environment and the majority of our muscle mass, as we described earlier, is distributed proximally, this will bias more of a proximal to distal dominant strategy. Okay, now there's nothing wrong with these two different behaviors or these two different strategies. Okay, because there's lots of scenarios where we would need to overcome forces and express more muscle activity to lift heavy loads. But the problems emerge when we're using force production or proximal to distal dominant strategies to manage forces, when we should be using more of a disturbance control or distal to proximal dominant strategy. Okay, and a common example of this is when someone experiencing low back pain or low back discomfort is expressing high levels of muscle activity, for example, around their trunk when they're going for a walk. In that scenario, it should be the distal tissues that are managing those direct forces from the external environment. And we need to step back and say, okay, well, do the distal tissues have the capacity to manage those forces? Or are we seeing an increased level of muscle activity proximally because of that lack of capacity distally? Okay, so here we have a big mismatch in the strategy being used potentially to handle those forces. And as therapists, as trainers, as coaches, it's our job then to restore appropriate strategies through challenging those neurological, those muscular, joint segmental, and also tensional behaviors, which is what we teach an awful lot in our courses. And the last point here as well, I think it's really important in that the nervous system is ultimately concerned about protection. It's concerned about the levels of safety, the levels of threat impacting our system, not necessarily optimal movement. Okay, so for us at IKN, we want to first develop the capacity to appropriately manage forces before we develop the capacity to overcome forces. And that requires a good, solid understanding of how the nervous system interacts with the anatomy and how the environment and task factors will shape those movement strategies. Okay, so let's look at these global interactions before we look at the local interactions. And if you're familiar with dynamic or complex systems theories, which we use an awful lot to guide the approach that we use, you should appreciate that the key behind controlling a very complex system with many interacting parts is by exploiting the interaction across many systems, across those many parts, or sharing the workload across many parts of the system. Okay, so you can think of a really badly coordinated orchestra where the music is terrible, okay, and the musicians and the instruments just aren't working really well with each other. They're not coordinating well with each other. you're not going to just single out the violinist, for example, and change the violinist's behavior and then throw them back in and hope everything is going to sound great again. Okay, you're going to target the coordination of all the individual parts and how they work together. Okay, instead of singling something out, and that's the equivalent of from a physiotherapy or kind of a health and fitness standpoint. That's the equivalent of singling out one isolated muscle and then telling someone that their pain experience is because that single isolated muscle isn't working properly. Okay, it just doesn't respect the coordinated nature of our movement system. Okay, now saying that, what if the violinist sprained their wrist a few weeks ago, and that's disrupting how all the other instruments are coordinating with each other? Okay, then we may have to single them out and work on them before we integrate them back into the system. Okay, and that's the same general concept. If we're treating somebody with an acute injury or a unique past injury, like a past ankle sprain that may be contributing to a hip pain experience on the same side, for example, then yes, we may have to do more local work around that ankle or around that acute injury before we integrate and begin sharing workload across the anatomy and looking globally before we look locally. In some cases, we need to go locally first. In other cases, we need to go globally first. Okay. So on the top left here, we have this interaction between different constraints based on the work of Carl Newell, where we have the interaction between the person, the task, and the environment. Okay, and a large part of our approach, like you saw on the last few slides, involves understanding these constraints or these factors on a deeper level, and then understanding how they interact with each other, and then integrating this into our assessment and treatment approach overall, or how we integrate those factors into our loading progressions. That's the key thing. Okay, and we've also looked at this interaction between top-down and bottom-up strategies. Okay, where the nervous system is during a top-down strategy, for example, where the nervous system is attending to the behavior of the muscles and joints more, and the bottom-up strategy, biasing a strategy where we're using the external forces from the external environment to ultimately guide the behavior of our anatomy and our nervous system. Okay, and a large part of that involves training or loading the movement system in such a way to reduce the micromanagement of our movement from the nervous system. Okay, because if we reduce the micromanagement from the nervous system, this opens up a lot more options to share load and forces across the anatomy. Okay, and you can think about this in a different example to the orchestra example. For example, you wouldn't want a boss that's constantly over every single employee's shoulder, trying to micromanage everything they do, trying to micromanage every single task that they carry out, because that reflects that the boss doesn't trust the employee's ability to get the job done. Okay, you'd much rather a boss that can delegate tasks and roles across the employees, where each employee has a different role, has a different behavior, has a different part to play. And this is what we want the nervous system to ultimately express as we move through the rehab process, because that allows for a sharing of workload across the movement system. Okay. And we've also spoken about this interaction between the nervous system, the anatomy, and the environment or task. Okay, but the one that is most practically applicable straight away is understanding this interaction between the midline tissues and the limb segment, and how those the midline tissues and the limb segment ultimately change their behavior within the context of the environment and the task. Okay, and the easiest way to describe this here is, because we get into this in much more detail in our courses, is that the midline tissues or the midline body region doesn't directly interact with the external environment. It doesn't directly interact with those external forces impacting our system. Okay, but the limb tissues do, the limb segments do, particularly the distal ends of the limb segments. Okay, so the limbs deal with direct forces, and the midline tissues or the midline body region deals with indirect forces. Okay, and this reflects the different roles or the different behaviors that the midline tissues and the limb tissues or the midline body region relative to the limb body region, the different behaviors that they express during whole body movement. And this is why we need to load the limb segments differently compared to the midline tissues across our rehab plans. Okay, so what are the global features that reduce central nervous system workload? And we briefly spoke about these capacities to reduce that central nervous system workload, where we can shift it from, or we can shift things from that annoying boss situation that's over your shoulder, trying to micromanage everything that you do, to a boss that trusts your capacities. Okay, and in this neuromechanical scenario, we want to get to a point where the nervous system trusts the low capacity of your anatomy to manage those forces well, coming from the external environments. So it doesn't feel the need to express these top-down protective behaviors like we see in the form of pain, which is probably the best protective behavior or protective strategy that we have. It doesn't feel nice, but it sure is very powerful at changing your behavior. Okay, but we have other common protective strategies that our nervous system expresses as well, in the form of a heightened level of muscle guarding around local interactions between joint segments, like a co-contraction of muscles around joint complexes, and that ultimately that co-contraction of muscles around a joint complex reduces variability and reduces movement options around that area. Okay, and this is something that we have to try to influence with our loading strategies, and it's going to influence how we sequence our loading progressions and regressions. Okay, and at the beginning of the rehab process, we might actually want to integrate a little bit of that annoying boss behavior, particularly if we're working to change local muscular and joint behavior. Okay, and this will be reflected through exercises where the intention is to increase the sensory feedback or increase proprioception from local areas to the nervous system. So the brain or the nervous system can have more awareness of that area, which can ultimately help reduce those protective behaviors. But we want to ultimately transition. We want to transition into whole body movement strategies. And when we're moving through more whole body movement strategies, integrating multiple joints instead of just single joint behaviors, this is where we don't want too much hyper awareness or hypervigilance or that micromanagement of joint angles and individual muscle or local behaviors. We ultimately want our movement to be less consciously orientated and more subconsciously biased through the anatomy. Okay, where conscious awareness is distributed into the external environment, again, to anticipate those external forces acting on our system. Okay, but there's a process we go to, right? Because there has to be a process to get to that point, and that's what we work through in our courses, where we're looking for that robust movement behavior. And robust movement behavior is really movement that can continue to be expressed while managing forces, while managing perturbations, while dealing with the uncertainties of the external environment. We can still continue to express our movements in the face of stress and perturbations. Okay, and to really navigate the complexity of the neuromechanical system, we need to consider these 4 different influences, these 4 different factors, which are neural factors, muscular factors, joint factors, and attentional factors or features or constraints. They're just features that shape our movement behaviors. Okay, because every movement that we express and every manual exercise or active exercise that we prescribe will represent these characteristics in some way. But we need to integrate them in a way that will guide a rehab plan in a step-by-step process from start to finish. So these are ultimately the endpoint goals that we're going to go through here briefly. Okay, so we look at the neural features first. Now, neurologically, we want to facilitate, like we see here, appropriate conscious and subconscious dynamics. Okay, where our nervous system is distributing more conscious control into the distal tissues, which will eventually be distributed into the external environments. Okay, where we're actually interacting with those external forces. Okay, and this reflects the importance of that distal feedback behavior, which is more reactive control, because the distal tissues are in more direct contact with the external forces. Okay, then the feedback about the nature of these forces becomes very important, and that's why we want more distal feedback behavior, where the nervous system is biasing a little bit more conscious control through the distal endpoints of the limb. Okay, and this is done while the proximal tissues express more feed forward or anticipatory control. Okay, because it's ultimately the hands, the feet, and the eyes that help us interact directly with the external environment, with the world around us. And we'll actually touch upon the importance of the eyes and the vestibular system at the end of the video as well. So if we look at things on a muscular level, we have to think about a couple of things here, because muscles are very complex. Okay, the first one being the muscular organization of distal versus proximal tissues. So if we look at the lower limb, for example, you have very short muscle fibers through the gastric and soleus distally, and short muscle fibers aren't necessarily designed to move through large ranges of motion, like the longer fiber glute max, for example, distributed proximally. We also have a very long free tendon distally in the Achilles tendon, and we have nothing like that proximally. Okay, so the shorter fibered gastric and soleus with more of a pinnate fiber organization is designed to bias more isometric behavior to help us quickly manage forces from the external environment. And it's this isometric behavior that allows the Achilles tendon to lengthen and shorten, to store and release energy. Okay, and again, if we look proximally at the longer fiber glute max, that doesn't have that pinnate fiber organization like the gastric soleus, but more of parallel fibered organization, we can appreciate that this muscle is designed to bias more concentric and eccentric muscular behavior or contractile behavior. And the important point here is that this doesn't mean that these tissues that can't do the opposite. Okay, it doesn't mean that the glute max can't bias more isometric behavior in certain situations. It doesn't mean that the gastric and soleus can't bias concentric and eccentric behavior in certain situations. But based on their unique architectural characteristics and the environmental forces that have led to this architectural design of the anatomy, we want to bias this kind of behavior based on those architectural features to improve the load sharing capacities across the anatomy. Okay, and on top of that, it's also important to appreciate the difference in behavior between monoarticular tissues and biarticular tissues. Okay, and this is really important to help distribute force across the anatomy, across broader surface areas. Okay, and lastly here, we want to facilitate contractile variability. Okay, which we have starred here because this would be a feature or an important capacity that we might want to challenge early in the treatment process and rehab process, where our muscular tissues develop the capacity to express each of these contractile behaviors to manage forces. So can they manage forces concentrically? Can they manage forces isometrically? Can they manage forces eccentrically? Okay, which will all help deliver that rich sensory feedback to the nervous system and build that cortical awareness early on. But again, the capacity to manage external perturbations and forces from the external environment acting on our anatomy requires a distributed behavior across our anatomy, okay, where distal tissues can express different behaviors to the proximal tissues, okay. We obviously want every muscular tissue to have the capacity to express different behaviors, but when it comes to managing external forces from the external environment, not every single muscle will express the same behavior at the same time. That's the key thing to understand. So let's move on to joint segmental characteristics here. Okay, and the interesting thing about joint structures is that the nervous system doesn't produce any motor output to the joint structures. It only receives sensory feedback or proprioceptive feedback from the joint structures. So it's ultimately the muscular tissues and the nervous system that dictate the behavior of the joints. Okay, but we can use the behavior of the joint segments and how they interact with each other, how they interact with the muscular tissues, to get an insight into how the nervous system is interacting with the muscular tissues. Because we often see across the research and people experiencing pain or persistent movement limitations, we often see a reduction in the variability between joint segments, for example, okay, which reflects a heightened level of muscle activity or a co-contraction of muscles around that particular joint interaction, which tells us that the nervous system doesn't trust the anatomy's ability to manage those forces moving through those tissues, those muscular tissues. Okay, so it puts the brakes on. And based on the work of Nikolai Bernstein, Carl Newell, Scott Kelso, and many other very smart people in the world of movement coordination, we've put together this framework that helps us work with joint behavior in a way that can help guide our loading progressions as well. Okay, and it's essentially highlighted by this transition to more of a freezing or in-phase strategy to more of a freeing or anti-phase behavior or movement strategy. Okay, which reflects our ability to control interaction forces as we move, because we're not just moving individual segments when we move, but these segments are interacting with the neighboring segment. And that actually creates an internal perturbation that needs to be controlled as we move. Okay, so we get into these joint behaviors, this freezing to freeing behavior, this in-phase to anti-phase behavior, and much more in our courses. But we also have this idea of segmental distribution versus concentration. So, for example, if I move my arm to reach for something on a table, for example, I need to pronate my forearm, which is an internal rotation of the forearm segment. Am I able to concentrate that internal rotation of the forearm segment, or do I need to internally rotate the humerus to distribute that internal rotation across the arm segment as a whole? So do I need to internally rotate the neighboring segment to facilitate that internal rotation of the forearm in that scenario? So it's ultimately about looking at capacities. Okay, we want individual segments to have the capacity to do both, to both concentrate movement at that individual segment and distribute movement across segments. But we might see problems emerge when they can only do one and not the other. Okay. And then lastly here, we're looking at the attention layer. Okay. Where is your focus of attention during movements? And for us, this is a feature that is very much overlooked in movement rehab, we feel. But ultimately, we want to move our attention distally and then eventually into the external environments where the forces are coming from, not necessarily internally and proximally, which often highlights these protective behaviors that we see in people with persistent pain and persistent movement limitations. And so in this slide here, we're looking at the local joint segmental interactions that will form a large part of our framework in the early to mid phases to guide our loading progressions and regressions. Okay, because another important point here to note that I don't think I clearly mentioned yet is that when we're assessing and when we're loading the anatomy, we want to do it in a way that respects the different behaviors that the midline body region expresses and the different behaviors that the limb body region expresses. Okay, and this is highlighted here in this slide by how we're organizing the interaction between the upper limb and the midline and the lower limb and the midline through a more of a local joint segmental lens. Okay, now when we look at the upper midline, for example, this would reflect the interaction between the rib cage and the cranium, or the rib cage and the head. So if we look at the upper limb and upper midline interaction, we've got the hand segment. If we look at it distally to proximally here, we've got the hand segment interacting with the forearm segment interacting with the humeral segment interacting with the scapula with the rib cage, and the rib cage with the head or the cranium. Okay. And so it's really important to appreciate that proximal upper midline behavior, the interaction between the rib cage and the cranium. We need to appreciate that interaction within the context of the rest of the upper limb, because the proximal tissues are essentially proximal extensions of the limb tissues. Okay, so you can't appreciate the behavior of one without the other. Okay, so trying to understand the behavior of the neck and the shoulder, for example, let's say we're working with somebody with neck and shoulder pain or any kind of limitation proximally, and we don't appreciate the behavior of the distal tissues, like the capacity of the distal tissues to manage forces from distal to proximal, or the local segmental interactions. Okay, that's like trying to understand the behavior of the digestive system without taking food into consideration. Okay, so we need to appreciate both. We need to always consider proximal behavior within the context of distal behavior, and also it works both ways. We need to appreciate distal behavior within the context of proximal behavior. Okay, and if we look at the lower limb local interactions, we've got the interaction between the foot segment and the tibial interaction with the femur with the pelvis, and the pelvis with the rib cage. Okay, and so understanding these interactions overall will actually help give us a much better understanding of the muscular behavior too. Okay, because for a muscle, for example, to express concentric and eccentric behavior, or shortening and lengthening contraction or behavior, the joint segments need to move in a way that facilitates that muscular behavior. So you really can't target one without considering the other. Okay, so now we're going to briefly explore some of the assessment and treatment and rehab concepts based on these neural, muscular, joint, and attentional interactions. And the first key concept is to identify global interactions before we try to narrow in and zoom in on the local interactions or local behaviors. So we want to establish or identify global behaviors before we look at local behaviors. Okay, and also we want to assess from proximal to distal regardless of the area of pain or limitation. Because what this does is it gives us time to form a working hypothesis about what we think might be going on, instead of trying to characterize the behavior of the movement system by looking only at the local area of pain or local area of limitation. Okay, so let's use low back pain as a quick example. Firstly, we want to try and organize our assessment to identify the general behavior of the midline relative to the lower limb by using certain assessment strategies. Okay, we want to do this before we look locally at the lumbar spine, at the local interactions around the lumbar spine. During this global assessment sequence as well, we're also looking at the general isometric behavior distally at the foot and the ankle here too, along with the general capacity to express concentric eccentric behavior proximally around the lumbar spine. So we're just looking at general behaviors here. So we're not just going to look at proximal behavior, we're also going to look at distal behavior here too, because we need to get an idea of the midline versus lower limb interactions as a whole. Okay, and again, looking at these global interactions also helps us give us an insight into the general strategies used to control multi-joint behavior or multi-segmental behavior before we just zoom in on single joint behavior or local behavior. Okay, and a huge amount of this will obviously be based on the unique context of the client's unique subjective history as well. It's going to determine where we place most of our focus. And then we're going to move more locally, okay, looking at the interaction between the rib cage and pelvis, so working proximally to distally here. We're looking at the interaction between the rib cage and pelvis, because the lumbar spine is really a reflection of the rib cage and pelvis interaction, how they interact with each other. The lumbar spine will flex when the rib cage flexes and pelvis extends. The lumbar spine will extend as the pelvis flexes and the rib cage extends. And then we're going to move distally. We're moving into the interaction between the pelvis and femur, the femur and tibia, the tibia and the foot segments. Okay. And then what we want to do is we want to try and identify how the muscles and joints behave when we add load and challenge to the system. Because it's all well and good looking at movement behaviors under low load conditions. But what we want to try and do is add challenge and load to the system. And we might notice a change in the behavior of muscles and joints, which will give us more information when we add more load to the system. And we're particularly interested here in the capacity of the biarticular tissues to distribute forces from distal to proximal here, because again, that's a key feature that will be important for us as we progress through rehab and learn to better manage those perturbations and disturbances acting on our system from distal to proximal. So let's look at a practical example here, and we'll look at the toe touch here, which is often used as a measure of hamstring flexibility, but it's so much more than that, because what it does is it gives us information about the coordination between the segments across the midline, particularly between the ribcage and pelvis. And it also gives us information about the low capacity of the lower limb to support that flexion of the spine. Because as the spine moves from extension and standing to flexion as we touch our toes, it'll actually move from a closed packed position to more of an open packed position, which represents a position where there's more variability between those spinal segments, which means that, again, it needs to shift that workload into the lower limb to manage the deceleration of that spinal flexion as the spine moves closer to the ground. Okay, so ideally, we want to see the spinal extensors have the capacity to unload that anti-gravity function, to unload that concentric activity to keep us upright, so they can express. We want to see them have the capacity to express that eccentric behavior. And this will naturally shift more workload into the lower limbs. So again, if the lower limbs don't have the capacity to manage load well, and they can't accelerate that forward flexion of the spine, which is really not just the spine, but the head, arms, and trunk, we might often see that inability to flex the spine, which is another reason we need to appreciate the behavior of the midline within the context of the behavior of the limb as well. Okay. But what we also want to determine here is how the rib cage and pelvis are interacting with each other during the toe touch, during spinal flexion. Ideally, what we want to see is the rib cage has the capacity to initiate that flexion, to initiate the beginning of the spinal extensor eccentric behavior. Okay, and we want the pelvis then to have the capacity to delay its forward flexion, to express more of an extended position or a posterior tilt early on during the toe touch to support that eccentric behavior of the spinal extensors, particularly the lumbar extensors, if it can maintain its extended position. Because if the pelvis flexes forward too early during the toe touch, and again, it will flex later in the toe touch, but early on, we want it to delay its forward flexion. If it flexes early during the toe touch, it's going to reduce the ability of the lumbar extensors to relax their anti-gravity function. And again, this is not necessarily a bad thing, but we want the pelvis to have the capacity. There's a big difference between having the capacity to do something than always expressing it during real-world movement. We just want it to have the capacity to delay its flexion, which allows for a dissociation between those segments. So as the ribcage flexes, the pelvis can stay extended. That's a dissociation in behavior between those two segments. Okay, so now they're expressing opposing behaviors, which again, Bernstein, other kind of work in coordinated research will identify that as more of an anti-phase strategy or a freeing strategy or a dissociation behavior. Okay, it just allows for the spinal extensors, particularly the lumbar extensors, to express that eccentric behavior that we want. Now, if you look at these images on the left-hand side here, I know these are still images, so they don't really give us a huge amount of information. But if we imagine that the guy in the top left here was able to flex the ribcage early on to initiate that spinal flexion and that eccentric behavior of the spinal extensors, but then if we imagine that his pelvis flexed forward very quickly early on during the toe touch, okay, then that would represent what Bernstein describes as a freezing strategy or an in-phase strategy where both segments are moving in the same direction, okay, which reduces their capacity to dissociate, and it also reduces their capacity to allow for the spinal extensors to relax and express that eccentric behavior. And if we look at the guy on the bottom left-hand side, let's imagine that he was able to flex his ribcage early on, but delay the flexion of the pelvis to allow for the lumbar extensors to relax. That would express more of a dissociation behavior between those two segments. Okay, but even in this guy's case, you could argue that the pelvis might not be able to flex very well. We're seeing a lot of lumbar flexion at the lumbar spine, maybe not a distribution of flexion across the whole spine. You could argue that. Because pelvic flexion is important later in the toe touch to allow for the glutes to express more eccentric behavior, to allow for the proximal hamstrings to express more eccentric behavior as well. But it's more about what happens across the range of motion during the actual movement and what we're seeing from a coordinative standpoint between the rib cage and the pelvis. Okay. And lastly here, let's discuss what it might mean if you see someone's knees bend. Okay. If their knees bend, it's not just the case where the hamstrings are tight, because there's proximal and distal reasons for this knee bending behavior. As an example, it could be a case where the knees are bending to help delay the flexion of the pelvis, because as the femur flexes closer to the trunk when the knees bend and standing, that will reduce the space that the pelvis has to flex forward. So it will help delay that forward flexion. But bending the knees also could be a strategy to shift more workload into the whole foot, because when the knee bends, the tibia will flex forward, and this will shift more load forward into the foot away from the heel. So it could represent a strategy where the system is searching for extra stability at the foot to help control the forward flexion of the spine. Okay, so there's lots of information that we can actually gather from this test. Okay, so looking at the toe touch test from a global and local perspective allows us to understand early on if the client might need more work distributed proximally between the rib cage and pelvis, or if we're able to progress the load distally much sooner. Okay, because that's another very important concept that we'll discuss later on, is the speed of progression from proximal to distal, based on lots of other information as well. Because of course, this is only one assessment. It doesn't give us all the information we need, but hopefully you can see what we're looking for here. Okay, so let's get into some of the key concepts behind the sequencing of our interventions and loading strategies, because many people will get worked up about trying to identify that one exercise that's going to fix limitations or fix someone's pain, which is a really unhelpful way to organize things in your mind and from a rehab perspective. What we need to do instead is appreciate that the movement system is a learning system. Okay, so it's more about the sequencing underpinning the delivery of load and the delivery of stimulus to help disrupt unhelpful movement strategies that are being used. as well as teaching the system to learn new ways of moving and expressing different strategies to manage forces and interact with the environment. Okay, so like we've said earlier, we're going to load the system in a proximal to distal manner. Okay, where we're going to work towards restoring dissociation behaviors between the joint segments proximally, and then working distally, and also improving the capacity of the muscular tissues to manage forces while we maintain those dissociation capacities. Okay, because with this, it will help the thought process. The intention behind this is establishing that proof of capacity to the nervous system. Okay, that our anatomy has the capacity to handle forces, while the joint segmental interactions can express more movement options. So we're trying to build that trust between the nervous system and the anatomy to prove to it that the anatomy has the capacity to manage those forces, and we don't need these top-down protective strategies. Okay, but the key thing here is that we're loading from proximal to distal. Okay, in this way, with the intention, we're loading from proximal to distal, but with the intention of restoring distal to proximal load sharing capacities, where the distal tissues can ultimately increase their load capacity to support the greater levels of variability that we've restored proximally throughout the process. Okay, and of course, this sequence will change if we have more of an acute situation, or if we're dealing with a distal issue with a lower limb. It could be a foot and ankle issue, it could be an elbow or wrist and hand issue in the upper limb, where we'll have to simultaneously work on proximal strategies while also improving the local behavior around the foot and the ankle, or the wrist and the hand, or where the acute injury has been sustained. Okay, so ultimately it's about the speed at which we're progressing from proximal to distal. And that speed at which we progress from proximal to distal will depend on the unique subjective factors, the unique objective measures that we've established during the assessment, as well as understanding how their system is responding to the load and the stimulus as we progress throughout the rehab plan. Okay, so we have 3 scenarios here. Let's go through a few short examples of how someone's subjective history, information like the nature of the onset, their symptomatic behavior, and their injury history, how this subjective information can help us think through the speed at which we're going to progress from proximal to distal. Okay, and we're going to do this within the context of proximal issues here. Okay, and again, like we said before, it will change with more distal issues, but again, we're going to use proximal issues here, so a low back pain experience or a neck and shoulder pain experience. Okay, so in the first example here, we have a client with persistent low back pain or neck and shoulder pain. Okay, we're just going to say for the rest of them, it's more proximal pain experience. So they've had that for the past 10 years. They've had 2 local surgeries proximally. So we have to consider that there's been some physical change to those tissues. They have no history of distal injuries, and their pain is worse at rest. Okay, and during that transition from rest to movement. Okay, so in this scenario here, we have a history of surgery proximally. Okay, with no history of distal issues. So already we should be thinking that we may need to do more proximal work, or direct more focus from a loading perspective proximally before we progress the loading strategies distally. Okay, what we're saying, the limitations proximally may be due to a limitation in the capacity of the proximal tissues to interact with each other well. Okay, there's also greater levels of pain at rest and during that transition from rest to movement, and this reflects that the motor system isn't able to reduce that protective muscle activity, that protective guarding around those proximal tissues at rest. And this obviously represents a mismatch in the strategy being used based on the demands of the task. We're just resting. The muscular tissues should be able to relax, but because of their unique history, the inability, I should say, to relax those tissues may be secondary to poor local load sharing capacities proximally, not necessarily poor limb load sharing capacity. So what we're seeing proximally may not be secondary to poor distal load sharing, but it may be due to more of a lack of local load sharing. Okay, so we're going to work from proximal to distal much more slowly. And in the second case scenario here, we have intermittent pain proximally for the past 7 years, but we have a history of distal injuries here. Okay, the pain experience is still worse at rest, and at that transition from rest to movement. So here, because of the nature of the symptoms and the distal injuries, we may have to progress to the distal tissues much earlier to have a greater influence over their symptoms. But because of their symptoms being worse at rest still, we may still have to do work, quite a bit of work proximally, to restore those local load sharing capacities. Okay, so we'll be interested in both proximal and distal behavior here more, but ultimately we're likely going to progress from proximal to distal at a faster rate here. Okay, and then in the last case scenario here, we have intermittent proximal pain for the past 3 years with a history of distal injuries, but no proximal past injuries. Okay, and in this case scenario, the pain is worse after prolonged movement, which we usually see at the end of the day. And in this scenario, we have to appreciate that the distal tissues need to have the capacity to interact with the external forces coming from the environment across the day and during prolonged movements. So if they can handle forces well, then we may see this increase in protective muscle behavior proximally, secondary to the inability to manage forces distally. Okay, so in this case, again, we may see we may not see a change in the symptoms proximally until we improve the low capacity of the more distal tissues. So we're likely going to progress from proximal to distal much faster here. Okay, so 3 cases there gives you a lot of information about how we can use the subjective history to guide our load sequencing. But obviously, the subjective history doesn't provide us with everything we need to determine what kind of load sequencing we need to deliver. Okay, or we're not necessarily going to use a subjective history to guide everything that we do during a rehab plan, but it can certainly help give us some ideas even before we work into the objective assessments. So this is just based purely on subjective history, but it can be really helpful to allow us to develop that hypothesis before we work into the objective measurements. Okay, so let's work through some potential strategies that we could distribute proximally to restore these local load sharing qualities between the proximal segments. So initially, we need to establish the local limitations. So during our objective assessment, we need to identify what structures are limited and what directions are they limited into. Okay, so let's say, for example, we have a client with lumbar spine pain. Okay, a pain experience around the lumbar spine. Let's say we've identified that the rib cage is struggling to flex, the pelvis is struggling to extend. Again, these are not bad things, but again, we want them to have the capacity to move in opposing directions, but also to manage forces as they're interacting with each other in different ways. Particularly, the goal is to get to the point where they can manage forces through the muscular tissues as they express dissociation capacities. Okay, and we also have a limitation in femoral internal rotation. So if, for example, we have a proximal pain experience without any distal issues, we may have to distribute a bit more focus proximally first. So let's say the first strategy that we use is directed towards improving rib cage flexion. Okay, and in order to try and isolate that flexion to the rib cage, what we need to do is we need to delay that pelvic extension as well. So we can use a standing wall-supported reaching strategy here where we position the lumbar spine against the wall. We have the knees slightly bent to facilitate that extension of the pelvis. And then we're using the foam roller to facilitate the reaching of the upper limbs to guide that rib cage into flexion. In this strategy, we can couple that with some breathing strategies. We can couple that with a gentle pressure into humeral extension to get some low load into the abdominal tissues, which will help to facilitate that flexion of the rib cage. We can also use some other strategies in quadruped to get a bit more load through the abdominals, where we're getting that reaching motion through the humerus, where the humerus is not reaching at 90 degrees or above, but it's reaching down. And when we reach down with a low humeral position, it's going to facilitate a little bit more rib cage flexion, which is going to help us get a bit more load into the abdominal tissues as well. Okay, so these are local strategies, more proximally driven strategies to facilitate a certain behavior at those tissues. And if we look at pelvic extension, for example, we're limited in pelvic extension. It's not a case where pelvic flexion is bad and pelvic extension is good. It's just that we want them to have the capacity to move in both directions, to give the system more options to distribute forces. What we can do now is with this one, we'll show you in the next slide, we can use some more kind of biarticular loading strategies to facilitate that extension of the pelvis, so we can get some load into the hamstring. We could get some load into the quads as well, particularly the rec fem, the biarticular tissue. But again, it depends on other objective assessments as well. We can do some supine hamstring loading, working from isometric to dynamic strategies. We can perturb then the distal tissues while we maintain certain behaviors proximally. We'll show you some options there, and I will talk through some options there. And we can also perturb the pelvic position or behavior through the femur as well. Okay, so for example, when we look at the pelvic behavior, we need to consider pelvic behavior within the context of the rib cage, but also the femur. As the pelvis extends, that will naturally facilitate more of an external rotation of the femur. As the pelvis flexes, that will naturally facilitate more of an internal rotation behavior of the femur. Those are freezing strategies. They're movements of the segments in the same direction. So with dissociation strategy, a freeing strategy between the pelvis and the femur would be represented by the capacity to extend the pelvis while internally rotating the femur, or just keeping the femur in the sagittal plane without dragging it out into external rotation with the pelvis. Okay. So again, we're getting some load into the biarticular tissues here, while maintaining those proximal behaviors. Again, the focus here from a joint segmental standpoint, because we want to ultimately kind of understand what's happening at the muscular tissues, but also what's happening through the joint segments as well. We're looking at the interaction between the rib cage, the pelvis, and the femur here. When do we use them to add more load to the system and facilitate those kinematic or segmental behaviors at the same time? So we're looking to facilitate ribcage flexion, pelvic extension, or just to maintain those behaviors as we work through them locally first before we move distally into the biarticular tissues of the limb. We could also use this for if we have a client with poor hamstring load capacity as well, because the proximal hamstring will help assist in the extension of the pelvis as well. Okay. On a muscular level, we can work towards kind of using more isometric bias strategies first, and then working into more dynamic strategies too. But again, when it comes to biarticular tissues, their capacity to distribute loads across broad surface areas is really reliant on their ability to work isometrically, to allow for the passive tissues to lengthen and shorten and store and release energy. So again, towards the end point of the rehab plan, again, we want to really improve the capacity of these biarticular tissues to work isometrically. So just to give you an insight here. So we want to flex the rib cage first, and then we're using the building of tension through the heel. Again, we're not driving any load into the metatarsal heads here, because we're not trying to challenge the distal tissues just yet. By driving load through the heel, it gives us the capacity to place a little bit more awareness on what's happening proximally between the rib cage and pelvis. So we're building that tension through the heel. We can flex the opposing femur to the chest as well, because that will facilitate that extension of the pelvis and just allow us to maintain that proximal dissociation between the rib cage and pelvis as we get load into the hamstring as well. Drive load down. We're scooping that pelvis off the table to maintain that extension. We can work through it dynamically. So initially we can work through it isometrically, where the pelvis is just barely hovered from the table 2 or 3 inches, but then we can work through it dynamically. So you're seeing a single leg dynamic strategy here, where we're trying to maintain that dissociation between the rib cage and pelvis and get that concentric and eccentric behavior through the hamstring, particularly through the proximal hamstring here. We can challenge this by changing the movement behavior of the ankle, for example. So if we plantar flex the ankle, that's going to challenge the flexion behavior at the knee, because typically what you'll see with these strategies is that when people are driving down through the heel, you'll see this flexion of the ankle, or the pulling of the foot back towards the head, which is a flexion of the ankle, dorsiflexion of the ankle. And this helps to facilitate that flexion of the knee, which is going to make it easier to get some contraction to the hamstrings. But if we wanted to challenge the hamstrings, we can keep that foot plantar flexed, or the ankle plantar flexed. And this is going to help concentrate a lot more load into the hamstring as we work through these strategies too. Okay. Now, what we can do here as well as a potential progression, and just keep in mind, these are really early phase loading strategies. We'll want to progress the speed, the amount of impact force that the limb is experiencing. We want to get them up into standing and work through more kind of challenging strategies as well. But we just want to give you an insight into what's going on during these early phase loading strategies. But what we can do now is we can start to challenge the distal tissues, so incorporating more distal loading while we hold on to that proximal dissociation. So still working with the rib cage, pelvis, femur, but now we're shifting more load from the heel into the forefoot. So can they maintain that proximal dissociation when the forefoot is being loaded? So now we're adding an extra segmental behavior via plantar flexion of the ankle. And the foot segment is very complex, so this is going to add a lot more neurological complexity to the control strategy being used. So you want to build pressure through the transverse arch, really try to drive that load through the first metatarsal head without lifting the lateral border of the foot off the foam roller, and allow the pelvis to hover during that strategy as well. Okay, we want to keep the heel hovered as well, and keep the load through the metatarsal heads. We can also start to challenge the position of the foot segment here by taking the ankle into more plantar flexion or dorsiflexion, but it's a similar type of sequence to the last strategy. We're getting that ribcage flexion, flexing the opposing femur, and then driving load through the forefoot, not letting that heel drop, so we can get some load into those plantar flexors here, particularly the soleus in this position here. But what you can see in this strategy as well is that the femur is no longer at 90 degrees. The femur is extended, which is going to challenge that capacity to maintain that proximal dissociation. So as the femur extends, that's going to try to flex the pelvis. So it's going to challenge the capacity to maintain that pelvic extension. So again, some example early phase loading strategies here, while challenging the load capacity of the muscular tissues, but considering the behavior of the joint segmental structures as well. Okay, so now let's work through some upper limb loading strategies. Again, these are very early phase loading strategies. Again, as we progress throughout the rehab process, we want to increase the speed, we want to increase the load, we want to increase the challenge on the upper limb and upper midline, okay? But initially, again, if the client needs it, we need to focus on more proximal strategies, proximal load sharing qualities first before we move distally. So in these two strategies we're going to show you here, we're going to look at the interaction between the scapula, ribcage, and humerus. Can they express dissociation as we get some initial load into the biarticular tissues, particularly the tricep in this case, in both these videos here. And we're going to show you kind of more of a proximal focus and a distal focus as well, based on the behavior of the hand and the forearm segments. Okay. But one of the key things to consider here is that when we're trying to build better load sharing qualities across the upper limb, it's very similar to the lower limb interaction with the lower midline, is that with the lower limb and lower midline interaction, we want the ribcage to flex the pelvis to extend to allow for the lumbar spine to express more variability in its movement options, so that we can shift more workload into the lower limb and improve distal to proximal and proximal to distal load sharing qualities across the lower limb. Similar concept with the upper limb, in the sense that we want the tissues on the posterior side of the shoulder, the upper rib cage, to unload that concentric behavior as well. Because in order to interact with the external environment and handle forces in a distal to proximal manner, we need that scapula to be able to protract and internally rotate. The protraction of the scapula is an internal rotation of the scapula. And that allows for these tissues in the posterior side of the rib cage to unload that anti-gravity function and build those capacities through the upper limb, through the biarticular tissues and all the other capacities that we're going to work on there as well. If we're constantly squeezing our scaps into retraction, then that's not going to allow us to really interact with the external environment very well. That's not going to help us prove to the nervous system that the limb has the capacities to manage forces. So initially, one of the key things that we're looking at is the capacity to flex the rib cage, protract the scapula, and then get that load into the biarticular tissues. And based on the subjective and objective measurements in the history, we may have to go even more locally and start to change the local interactions between the ribcage scapula, even head and ribcage, or scapula and humerus as well, before we get load into the biarticular tissues. But again, more information is needed to identify if we're going to put more work and more load through those local interactions proximally before we work distally. Okay, so we're going to show you some strategies that we can use to get some load into the triceps here while maintaining that proximal dissociation. So I'll bring it up on the full screen here. So this is just a tall kneeling strategy with the chair in front that gives us the capacity to unload these tissues on the posterior rib cage, get load through scapular protraction, and then get load through the triceps via forearm extension, via the fist. Okay. Now this position is nice because the humerus is below 90 degrees of humeral flexion. So what that does is that reach then allows us to facilitate that ribcage flexion versus reaching in more of a higher humeral position will facilitate that ribcage extension, which we eventually want to get to later on in the rehab process if we're working with a limitation in humeral flexion, for example. But all we're going to do here is we're going to reach that elbow down, okay, to unload those tissues posteriorly, and then we're building pressure via the fist to get some load into the triceps, okay? Now, what you're going to see here is that we can, well, you're not going to see it in this video, but what we can do here is we can challenge the dynamic movement on the elbow. There's lots of other ways we can challenge it as well. But one of the main things we want to do here is just get some initial load through the tricep while we give the nervous system the experience of that dissociation capacity proximally, okay? What's also happening here as well is that, again, we have that scapular internal rotation, but because the elbow is facing the ground and the bicep is facing forward, that humerus is in relative external rotation relative to the scapular internal rotation. So we're getting that initial dissociation between these segments. A lot of times clients will struggle to bring that humerus into external rotation. It will actually go out into internal rotation, which would represent more of a freezing strategy, which is oftentimes what you see when we move the forearm segment into pronation. If they don't have that dissociation between the forearm and humerus, as they start to pronate the forearm, you'll start to see that humeral internal rotation, which will lead to an inability to express that dissociation between the scapula and the humerus. Okay, so you'll see that example here. Put this on full screen as well, where a way to start to shift a little bit more challenge into the distal tissues is by driving a little bit more of a flexion torque via the hand segment, via the wrist, which gets us more load into the forearm, into the wrist and finger flexors, okay, while still trying to get that load into the triceps. And again, this is really early phase loading strategy, but it can be quite challenging for the clients when we're trying to maintain those proximal dissociation capacities. Getting that load through the whole hand, the fingers, the metacarpal heads, feeling that load through the forearm flexors, or into the anterior compartment of the forearm, into the tricep, all the while we maintain those proximal dissociation capacities. Okay, really important to begin to get that load distally. But again, the speed at which we progress that load distally will depend on what we find during the subjective and objective history as well. Okay, so lots of ways we can add more local strategies within these positions. Okay, and that's what will typically change as we progress across the rehab process. And then as we progress our loading strategies, again, we're not just going to jump into these kind of hopping strategies, but just wanted to give you an idea of how we can really challenge the distal tissues a little bit more. We can add speed and impact forces to the distal endpoint of the limb. So it's more of a distal dominant strategy. We're improving that distal to proximal sequencing, where the distal tissues are building that capacity to manage those forces, because we do have long free tendons in the forearm as well via the flexor digitorum profundus and superficialis. They're obviously not they don't express the same characteristics as the Achilles tendon in the distal lower limb, but it does represent that the hand, wrist, and forearm should have the capacity to express these elastic behaviors as well. And what you're going to see here is we're obviously in a little bit more of an extended ribcage position. We're trying to hold on to a little bit of protraction capacity as the humerus maintains its sagittal plane orientation as well. We're not going to get into too much detail about the need to maintain dissociation within these plyometric strategies, but it can be an important feature early on during these plyometric strategies before we start to challenge even more speed and add more impact forces to the upper limb. So we're working through the whole hand here. We're just adding that little hop off the wall, and then we're going to build the speed. We're going to build the continuous nature of those hops to really challenge the isometric capacity of the wrist and finger flexors, which is going to put a lot more load into the forearm tissues as well. So really encouraging the nervous system to shift that attention distally into the hand, the wrist, and the forearm, build these capacities to support the variability that we would have worked towards restoring proximally earlier on during the rehab process. But again, like I said, the amount of work that we put proximally and distally will depend on the unique subjective and objective information that we identify during the the actual evaluation, the early phases of the evaluation. And again, we're not only working on distal features here, we're also working to progress towards proximal dominant strategies too, to improve proximal to distal sequencing, where it's not about managing forces, but it's also about producing forces. And that's when we want to actually put more focus into the proximal tissues. Okay, we're actually producing forces from proximal to distal. And so the sequencing of these loading strategies, again, is important to understand as well. It's not just about trying to identify the one exercise, the one stimulus, the one um, strategy that's needed to change things. We're trying to disrupt unhelpful strategies. We're trying to build new strategies. We're trying to build new movement solutions that the nervous system can use to manage forces without having to express these top-down protective strategies in the form of pain or in the form of heightened levels of muscle activity. Okay, so we're trying to reduce the need for pain. We're trying to reduce the need for these top-down protective strategies. Okay, so up to now, we've been mainly looking at the behavior of the proprioceptive system and how the nervous system interacts with the muscles and joints to handle forces. Okay, but we also have to consider these systems within the head, within the cranium, that help to facilitate changes in muscle activity, particularly across the spinal tissues, the midline tissues. And those are our visual system and our vestibular system. Okay, so as part of someone's rehab plan, depending on their unique subjective and objective history, we might want to identify the low capacity or the low tolerance of these systems. And again, particularly within the context of midline or spinal behavior. Okay, we don't want to just jump into these systems too soon. So if we look at the visual system, for example, the visual system gives us the capacity to identify the source of forces and potential perturbations in our external environment that may potentially impact our system before they impact our system. So being able to move the eyes relative to the head is key to help our anatomy anticipate those forces that will potentially impact or act on our system. So they contribute to good perturbation control or disturbance control. So if, for example, we can't anticipate those forces through the visual system, we may experience more forces acting on our anatomy, or it may be a case where we're not able to respond as quickly to those impending forces. Okay, and this is becoming a very important feature in the research that's being considered during ACL rehab, for example. Okay, now another key feature of the visual system is the capacity to dissociate the eyes from the head, so they can move in opposing directions, so they can dissociate from each other essentially. And again, this allows for a sharing of load across the head and neck, because when we can dissociate these segments, the eyes are a segment, just like any other segment across the body. When we can dissociate those segments, the eyes and the head, it actually helps to reduce the muscle activity across the cervical spine. So it's a very important feature to be able to express, particularly within the context of pain around the head and neck. And lastly, one thing that we often see when our anatomy as a whole, our body as a whole, loses the capacity to manage forces or manage gravitational forces, is we'll see a shift to a more visual dominant strategy, okay, where we lose our peripheral visual awareness, which creates a midline stiffening strategy and reduces our ability to share workload across the midline tissues. And you'll see this widely across balance control research. Okay, so what we essentially want is we want the eyes to function as a fifth extremity or limb. Just like the limbs dissociate from the midline, we want the eyes to be able to dissociate from the midline to help us interact with the environment. But we don't want to target the visual system too early unless it's clear from the individual's subjective and objective history that there's a potential low capacity issue there. Okay. Now, when it comes to the vestibular system, this is really a system that can't be separated from the eyes. Okay, because what it does is it tells our brain through head movement where our body is relative to gravity, which is very important to quickly and reflexively alter muscle activity across the body to manage those body and positional changes relative to gravity. So you have two motor output pathways from the vestibular system. One motor output pathway to the eyes to help reflexively change eye movement relative to the head to keep our eyes on targets as we move. And the other motor output pathway is to the spinal tissues, the vestibulospinal reflex, okay? And this allows us to quickly alter muscle activity across the spinal tissues to keep us upright relative to gravitational forces. So if we have poor load capacity through the vestibular system, we may observe poor reflexive muscular control across the spine, which is often represented by increased protective muscle guarding, okay, or increased co-contractions across the spinal tissues as a compensatory control strategy, you can say, which is widely seen across research into vestibular contributions to balance control. Okay, so it's important to consider that as well within the context of spinal or midline behavior. So again, the key thing about these top-down lines of communication from the visual system and the vestibular system is that while they are important to consider, we don't want to just jump straight into improving their low capacity unless it's clear from the assessment, okay? What we want to do first is improve these bottom-up strategies and then target these top-down strategies if necessary. So lots of information covered there, but again, we're really just scratching the surface when it comes to this information in this webinar. So I just want to briefly go through where and how you can learn more about this information with us if you found it interesting. And so if you want to learn about these concepts in much more detail and learn how to integrate them into more of a full assessment and rehab plan for those 3 key body regions, the upper limb, the midline, and the lower limb, then our level 1 and level 2 options would be the best place to start. We have online options, which are 8 weeks in total and self-paced, and you get lifetime access to the material. And then we have also our 2-day in-person options too. Now, if you want to learn more about higher speed, higher load, and more sensory-driven exercises to supplement your performance strategies, then our IKM Performance will be a great place to start as well. And we have an online version here too, and a 1-day in-person option here as well. Okay, and probably the easiest place to start learning about the specific muscular and joint interactions through this framework and how we can progress and regress based on this muscular and joint framework to the freezing to the freeing strategies would be to check out either our IKM mobility course for the upper body and lower body, or the manual therapy online course if you're able to put your hands on clients to facilitate change that way. Okay, so those are great options too. So I just want to say thanks so much to everyone. If you made it this far, thanks for listening. Hopefully this information and the concepts that we've covered resonate with you in some way. And if you have any questions about any of the material, then feel free to reach out to us directly. And thanks again.